Good morning, everyone. Today, I am going to present the topic of neurophenotype in ataxia telangiectasia. Ataxia telangiectasia is a monogenic disorder of which affects mainly the CNS system and also other systems such as immune system and also skin. So we'll be mainly dealing with the uh, neurological manifestation of this disease and which is various movement disorders, peripheral neuropathy, and oculomotor manifestations. As I already said, the disease is having a multitude of other manifestations, especially skin manifestations like multiple caffealo spots, or there can be ocular telangiectasia and other neurocutaneous manifestations, and especially other thing like immunodeficiency, in which there is specific IgG subclass deficiency, and the patient can present with recurrent sinopulmonary infections. But here today we are dealing with mainly the neurological manifestations, which is very characteristic and which is a clinching point towards our diagnosis. So these are the movement disorders in ataxia telangiectasia. They are mainly cerebellar ataxia, dystonia, Parkinsonism, choreoathetosis, myoclonus, and tremor. The point we should be noting here is that there can be these movement disorders can be present at different points of the disease course. But the importance is that which all manifestations are present during the onset of the disease and at what point does they all of them present become present in this disease. So cerebellar ataxia is the very common and characteristic finding in ataxia telangiectasia, as the name itself implies. So initially, it mainly comes in the young onset type, and in young onset type, ataxia can be a presenting symptom, and then it appears to progress and then plateau by 3 to 5 years when child actually acquire composite motor skills. When the child attain more development milestones, this the child is able to compensate the ataxia by the new skills. The appendicular ataxia, such as dysmetria, dysdiadokinesia, intentional tremor, all those things are present around 5 years. Cerebellar ataxia is less disabling. This is important because there are other movement disorders which are more disabling in ataxia telangiectasia, and it is very uncommon in older age of onset. Choreoathetosis and choreoathetosis also are rarely disabling. This also can be a prominent manifestation. Sometimes the patient can present with choreoathetosis itself. If at all the initial manifestation is choreoathetosis, they tend to have a generalized symptom associated with gait instability. Chorea is a infrequent initial manifestations, but you should suspect ataxia telangiectasia if chorea is associated with dystonia also. Dystonia, various areas of body can be associated with dystonia, such as face, limb, and tongue. It initially symptoms occur only on action, but then later towards even at posture or various even at rest, you can get dystonia. There can be cervical dystonia, and it typically appears in the second decade. And dystonia is very much disabling in ataxia telangiectasia, unlike the cerebellar ataxia or the chorea. Tremor also is a kind of extrapyramidal symptom which can be present in ataxia telangiectasia, and it can also be associated with Parkinsonism. Tremor is initially prominent in postural and kinetic states and less at rest, which is contrary to the idiopathic Parkinsonism which we see. Mostly tremor is asymmetrical and it largely affects the upper limbs. Parkinsonism also can be a feature you can get in ataxia telangiectasia. However, it is rarely an initial manifestations, and it is associated with other features of Parkinsonism such as paucity of spontaneous movements, decreased facial expressions, and a postural instability. Myoclonus also is a very rarely a initially presenting symptom in ataxia telangiectasia. Now, this is an important chart which shows the prevalence of the movement disorders and the initial presenting movement disorder. In this, you can see that almost all the movement disorders which we have discussed here comes to the play in some point of disease. Is mostly the prevalence is very high in all these cases, but the onset, they as a presenting sign is variable. If you can notice this, myoclonus and Parkinsonism, no one presents with myoclonus and Parkinsonism in ataxia telangiectasia. However, in the temporal course of disease, you can see that myoclonus is increasing to 92% and dystonia and Parkinsonism to 41%. So this is the important thing. Now, oculomotor manifestations, there are various manifestations like especially in saccades and smooth pursuit movements. There can be saccadic dysmetria, that means the saccades can be broken, it may not reach the target. There can be difficulty in smooth pursuit movement, a moving target is difficult to follow, and there can be gaze holding defect where the saccades intrude to the pursuit movements. There can be periodic alternating nystagmus where the direction of the nystagmus change within a span of 2 to 3 minutes. All these together constitute oculomotor apraxia, which is a very prominent feature in ataxia telangiectasia. There can also be peripheral neuropathy. Now, the peripheral neuropathy, the study which they have done has shown that hyporeflexia, atrophic skin changes, muscle atrophy, they presented various time course of the disease. And also the involvement of peripheral neuropathy is also very characteristic in this study. Upper limb had demyelinating motor neuropathy, while the upper limb sensory neuropathy was a mixed type. And the lower limb had actually motor neuropathy as a mixed type and the sensory neuropathy also as mixed type. So, which means that there can be peripheral neuropathy in ataxia telangiectasia and the involvement is characteristic. However, the type of neuropathy is different in different domains such as motor and sensory, and it also is different in upper and lower limb, such as one can be demyelinating, the other can be mixed or axonal. Mainly the take-home message of this presentation is that neurophenotype of ataxia telangiectasia is very complex, that it involves multiple localizing areas. You can get a clinical feature of neuropathy, you can get a cerebellar signs, you can get extrapyramidal manifestation. So as such, it has a multiple localizing areas. However, the involvement of the various patterns such as movement disorders, peripheral neuropathy, and their temporal course, and also the association with other manifestations such as multiple cephalosports or immunodeficiency can be point towards the diagnosis. Even though the involvement of there are involvement of multiple regions, they have a more or less definite pattern by which part is involved and in which manner, and has a predictable temporal course. Hence, pattern recognition and the is important for the accurate clinical diagnosis. Thank you.